Thank you very much, Sibylle, and thank you everyone for coming to the seminar, and Happy New Year. Sibylle, you have the honor of being the first speaker of 2022. Welcome. So Sibylle is a principal scientist at the EO Research Institute in Davos, Switzerland. She's the deputy program leader of the Regenerative Orthopedics program, and she focuses on intervertebral disc and cartilage biology. So she obtained her PhD in natural sciences from the Department of Cell Biology of the Federal Institute of Technology in Zurich. After completing her postdoc training, she then joined the EO Research Institute in Davos. So Sibylle has since then acquired a lot of expertise in tissue engineering, regenerative medicine, and her main focus is on, as I said, cartilage and intervertebral disc repair and regeneration. So she has a number of projects and does really beautiful science. So some of the projects include doing organ culture and really state-of-the-art bioreactor studies for the intervertebral disc, cell therapy, molecular therapy, circulating and tissue biomarkers. She also looks at bioreactor-loaded explant models for cartilage and osteochondral defects. And so her expertise in advanced ex vivo organ culture systems for studying both degeneration and repair is well widely acknowledged. Sibylle is also a private docent with habilitation at the Federal Institute of Technology in Zurich, and also a course leader in the graduate program of the Department of Health Science and Technology. She obtained a lot of funding from many national and international agencies and has been a section leader of several collaborative projects. She's a co-organizer of the ECM meeting annual conference and has served as the topic chair, section research chair, and program committee member at the Orthopedic Research Society. So Sibylle has published more than 140 peer-reviewed articles. So it is a pleasure to welcome my friend and an excellent scientist, Sibylle. So yours, Sibylle.
Yeah, thank you very much. And thanks to Michael and Faxon for the kind invitation. In the meantime, we are used to online seminars, but of course, I would be happy next time, maybe even to visit you in person. So today, also most of you, or the ones who know me more for my spine research and organ culture and intervertebral disc research. But I'm also involved in many cartilage-related projects. And therefore, I thought as a change today, I'm going to talk about chondrocyte and stem cell-based cartilage regeneration and how the biomaterial and biomechanics affect the outcome. Just as a brief refresher, the articular cartilage is the tissue that covers the joints, and it allows for low friction motion between the bony ends. First, and second, it distributes the load over the whole joint surface. Very similar to the disc, also the articular cartilage is avascular, lymphatic, has no nerve cells, and only sparsely distributed chondrocytes in the matrix. Also similar to the intervertebral disc, we have to say the extracellular matrix contains a lot of water, more than 85% of water, collagens, and proteoglycans. The articular cartilage is divided in 4 different zones, which include the superficial zone, that allows the lubrication, then the middle zone, the deep zone, and the calcified zone. And defects in the articular cartilage can occur either as chondral defects, where just the cartilage layer, the cartilage zones are affected, or osteochondral defect, where the defect goes down to the bone, to the subchondral bone, so where the bone and the cartilage are affected. So there are treatment methods, so standard current treatment methods especially for chondral or also partially osteochondral defects include, for example, autologous chondrocyte implantation, where a biopsy of healthy cartilage is taken from the patient. The cells are isolated, cultured, grown up, and injected into the defect site. And another method that is still considered one of the gold standards is microfracture, where the cartilage defect is made accessible to the bone marrow by perforation, and then the bone marrow, including the mesenchymal stem cells, the mesenchymal clot, is infiltrated in the defect. However, as we know, in these cases, especially in the case of the microfracture, often not really articular functional cartilage is built as a new tissue, as a near tissue, but more like fibrocartilage that is mechanically inferior. So we ask us, what can be the problem and how could this be improved? So one factor that is often underestimated is the mechanical stimulus. So the mechanical stimulus is very important for regeneration of the cartilage, either for stem cell based or microfracture based, or for chondrocyte based. So for example, autologous chondrocyte implantation. If we have cell-based matrix, for example, matrix-assisted autologous chondrocyte implantation that is implanted into the defect, then it is considered that by the patient movement, the construct would mature in the defect. So in order to really regenerate a natural, functional, mechanically competent cartilage. This mechanical loading is important because also in vivo, the cartilage is always exposed to different loads, such as compression, compressive load, shear load, or also hydrostatic pressure. So therefore, also for cartilage regeneration, an appropriate mechanical stimulus is needed in order to regain and resurface the cartilage. But how to reproduce this, how to study this in vivo? So as we know in vitro, as we know in vivo, there is a complex motion on the cartilage. Therefore, almost 20 years ago, we started designing and developing a bioreactor that can reproduce all the different complex motions and stimulate the cartilage constructs or tissue engineering constructs. So this would be the tissue engineering construct or a piece of cartilage, also in an ex vivo or in vitro situation. So here I can show in a short video how it works. So inside is the construct. So the red is the cell culture medium. And then this is in principle a ceramic hip ball that is used also for hip replacement. And this is important to have a really very smooth surface. It moves up and down, and at the same time, it also oscillates around its axis. And in addition, we can also oscillate the scaffold to reproduce more or less a physiological motion, a physiological movement that would occur, for example, in a knee. Our standard protocol, here you see again, this would be a tissue-engineered construct, a cell-seated scaffold, and a ball that is moving then up and down. Our standard parameters are like, for example, a polyurethane scaffold, polyurethane fibrin scaffold seeded with chondrocytes or mesenchymal stem cells. And the cells are seeded in a fibrin gel to allow the 3D environment. And in addition, the fibrin gel is further seeded into a polyurethane scaffold because the polyurethane scaffold has the advantage to be very elastic and resilient. So you can compress it up and down and it would always come back, but it needs a certain stiffness for the mechanotransduction. Our standard parameters are the 10% strain. So 10% means 10% of the scaffold height, which is about, standard size is 4 millimeter in height, so around 0.4 millimeter strain, cyclic strain at 1 Hertz frequency during 1 hour per day. And this is sufficient to optimally stimulate the cells that are in the scaffold. So in initial studies, we looked specifically at the effect of this compression and rotation. Rotation means the ball rotation I just showed in the video, compared to constructs that were loaded by compression only. So what is interesting here, that independent of the strain amplitude, now 10 or 20, or even in a static manner, as soon as we have the ball rotation, there is a significant upregulation of the gene expression of the superficial zone protein or proteoglycan 4, or also known as lubricin. So this lubricin is really upregulated as soon as we stimulate the cells with this ball, with this shear load. So which indicates that really the shear load is necessary to produce the lubricin. This could also be shown in the cell culture medium, where we only have lubricin in the medium. So this is the control, and this is the compression only group, where we have no lubricin. We only have lubricin in the medium when the scaffold was loaded with compression and ball rotation. So it upregulates the gene expression and also the protein of lubricin. We also tested what the influence of the loading velocity is, like the oscillation velocity of the ball. And here we looked at COMP mRNA expression. Why COMP? Because we had found that COMP, besides lubricin, I have to say, besides lubricin, COMP is one of the most responsive genes that are expressed in response to the mechanical load, and especially in response to the shear load. When we tested different frequency of the ball rotation or also of the scaffold rotation around its axis, we found out that at the highest loading frequency of 1 Hertz, the COMP mRNA expression was most significantly upregulated. So higher than at the 1 Hertz ball oscillation, but we calculated then the relative velocity that is experienced by the cells, and we could show that at a higher velocity, the upregulation of the COMP was also higher. So based on these results, our future studies were then done with the 1 Hertz, with the 1 Hertz ball oscillation, because after discussion also with some biomechanics experts, we said that higher than 1 Hertz, like 2 or more Hertz, would not be physiological and would rather be detrimental for the construct. We then looked more specifically at the histology, at the immunohistochemistry outcome of these constructs. Again, we have a scaffold. This is a scaffold that is seeded again with chondrocytes and loaded under different conditions and cultured for 3 weeks in vitro with or without 1 hour of mechanical loading. What we can see in this group, so this is the non-loaded control. So these constructs have not been exposed to any load, just cultured in free swelling. We see not a nice, quite a minimal type 2 collagen expression. We see too much collagen 1, which is indicating like more fibrocartilage formation. We see a little bit of aggrecan, but much less than in the others. And we see in this case, no lubricin or no superficial zone protein at all. When we expose the same scaffold to only compressive loading, so we have the ball that compresses, applies cyclic compression on the construct, we can see a bit more type 2 collagen, a bit better distribution, still too much type 1 collagen, also a bit less than in the unloaded, but a good amount of aggrecan, so a good amount of proteoglycan production, but still no lubricin. Then only when we expose the construct to compression and shear, so compression and ball oscillation in this case, so it's a simultaneous loading of cyclic compression and ball oscillation, we can see a nice distribution of collagen 2, also a nice distribution of collagen 1, again a good aggrecan, and here we can see the lubricin. And this is, this is the most similar to the positive control. Of course, we also run a positive control, which is just native cartilage, which can see, where you can see how it should finally ideally look. We have the most similar condition in the construct that were really stimulated by this loading. Quite good collagen 2, minimum collagen 1, quite good proteoglycan, and also very, very important that a very thin layer of lubricin that we can see here at the native cartilage surface and also here in the superficial cells. We can see it very similarly in the loaded and the tissue engineered construct. And in this construct that had most of the lubricin, we could also see that the coefficient of friction was significantly lower in these constructs. The coefficient of friction was measured at the end of the culture period. So at the end of the culture period, we did some atomic force microscopy to estimate the coefficient of friction. And we can see that in the control group that is not loaded, it is much higher than in the loaded group and even significantly higher than in the loaded group 2, which is the compression and shear load. So this is the compression load only. So this really indicates that by compression and shear load, we can upregulate the lubricin expression in the construct, which also leads to a lower coefficient of friction coefficient in the tissue engineered construct, what should be then the ideal case for functional cartilage. So before these experiments I showed before were all done in healthy chondrocytes, usually bovine chondrocytes, healthy under physiological conditions. However, and this is another publication that shows that in fact, when in clinics this matrix assisted chondrocyte implantation is done, so you isolate the chondrocytes from the patient, you grow them up, you seed them on a matrix, and you re-implant them. In a lot of cases, you do this in a degeneration state, which means that often you probably do have also kind of an inflammatory condition. Although this is, in general, I think officially it's a contraindication, but nevertheless, in a lot of cases, you have an inflammatory environment when you actually do this. Therefore, we also wanted to investigate, so what happens if we have the same bioreactor experiments, but we simulate an inflammation. So we did the same experiment with chondrocytes, however, seated in a scaffold and loaded in the bioreactor. However, we have one group where we added TNF-alpha, and in this group, we kind of simulate an inflammatory response or an inflammation state. It's a bit difficult to see here, but looking just at the loaded group, for example, we can see the control, we can see the TNF-alpha has much less extracellular matrix built than the control. Then we added adalimumab, which is a very well-known anti-inflammatory drug, which helped to reduce the effect of the TNF-alpha, which helped, to reduce the effect here. We have TNF-alpha and adalimumab, helped to reduce the effect of the TNF-alpha. And we even concluded that under loading, it has even a bit of positive effect. So we concluded that even in an inflammatory condition, probably the combination of the adalimumab, so an anti-inflammatory drug, locally applied, and moderate mechanical loading would be most beneficial for efficient regeneration. So, but what happens in the other case? So far we have talked about more like chondrocyte implantation, but what happens in the case of mesenchymal stem cells? For example, if we want to implant mesenchymal stem cells in a tissue engineering construct, or also in the case of microfracture, what I said, when we have the stem cells from the bone marrow coming into the defect, and then they are mechanically loaded. So what helps best for differentiation of the stem cells towards the chondrogenic lineage? We did the same experiment in the in this fibrin polyurethane scaffold, but this time instead of seeding chondrocytes, we seeded stem cells. We again have different groups like compression only, compression loading stimulation, shear loading stimulation, compression and shear load, and no loading at all. What you can see clearly that only in the group where we have compression and shear, there is a chondrogenic response that can see in histology by these metachromatic staining of toluidine blue stained sections that clearly indicated the generation of proteoglycans. Whereas the compression only group really did not show any response. Also the shear only group and the control even showed quite a massive, again, like fibrotic response. So this shows that the compression and shear not only is beneficial for the lubricating surface, but in the case of mesenchymal stem cells, also beneficial to actually differentiate the MSCs towards the chondrogenic lineage. We looked a little bit more into detail what's happening, and there we saw that the response depends on the supplementation of TGF-beta in the cell culture medium. Interesting, the upregulation of chondrogenic genes, the traditional ones like agrican and type 2 collagen, only happened significantly under load when there was no TGF-beta in the medium. When we do have TGF-beta, then the difference between the loaded and unloaded groups between the black and white were really minimal for both the agrican and for the collagen 2. So which indicates that in the case where we do have the TGF-beta, which is already a very potent chondrogenic stimulus, we kind of mask the effect of the loading. So the loading, however, in vivo, we usually don't have TGF-beta, especially not in these cases. So again, this would reflect the in vivo situation, that there is no TGF-beta in the synovial fluid, I would say, and then the load can really upregulate aggrecan or type 2 collagen. We even looked into more detail, and we could demonstrate that the TGF-beta 1 and TGF-beta 3 both, in the case where no TGF-beta in the medium, were upregulated by load. So to make a long story short, when we apply the mechanical load, when we apply the mechanical compression and shear loading, then the cells are stimulated to upregulate the TGF-beta on the gene and on the protein level. And we found later out that this is both due to mechanotransduction processes, but also through direct mechanical influence. So latent TGF-beta is directly converted to active TGF-beta just by the pure mechanical stimulation. How this could happen is, so we asked, so which cells are now actually responding to the stimulus? And therefore, in one experiment, we did, this would be again the scaffold. And here we will have the seeded cells, again, a bone marrow derived mesenchymal stem cells. So here in this group, we have randomly distributed cells in the scaffold. Here we have cells in the scaffold and cells on the top layer, in addition, a layer of cells. And here we only have the layer of cells on the top. And what is interesting that in this case, we have the most pronounced chondrogenic response of the cells. Here we have the safranin O staining that again indicates proteoglycan production. We think because in this case, we have a layer of cells that are in direct contact with the ball. So these cells are directly stimulated by the mechanical stimulus and are more stimulated than these cells down there that are only indirectly stimulated. So the directly stimulated ones, they would produce the TGF-beta, as I said, and then the TGF-beta is then again activating these cells to undergo chondrogenesis. And therefore, we have more chondrogenesis in these constructs. Okay, so far I have mainly talked about like cell stimulation, or I would say cell-based cartilage regeneration. But more and more people are also looking towards like cell-free approaches. So a cell-free approach would be, for example, if you have, again, you have a defect, an osteochondral defect or a chondral defect, and then you implant a hydrogel that might contain some chemotactic factors, and then the chemotactic factors and the hydrogel would allow the migration of cells into the from the surrounding tissue into the defect in order to repair the defect. So we were looking which type of hydrogels would be most suitable for allowing cell migration, and whether the chemotactic factors such as PDGF would enhance this response, so would facilitate the migration of cells into the defect. Therefore, we first did an in vitro experiment where we tested different types of hydrogels. So this is a fibrin hyaluronan hydrogel that was produced by a collaborator of us. And here we have different types of hyaluronan tyramine hydrogel in different stiffnesses. So this is the stiffest one, and this is the has a less stiffer mechanical property hydrogel. And in addition, we added the chemotactic factor PDGF into the hydrogel, and this is the group without PDGF. Because in a previous study, so in a preliminary study where we tested different chemotactic factors, we found out that actually it was the PDGF that had the most significant chemotactic effect, similar to also SDF1, so but less to than other chemokines. So, but these results clearly show that in the case of the fibrin hyaluronan hydrogel that contains the chemotactic factor, the cell migration. So we have a spheroid of cells that migrate out into the gel, but more pronounced than in all the other groups. And of course, the PDGF helped to facilitate cell migration. So we thought that this hydrogel with the PDGF is probably a good candidate to implant into a cartilage defect. Therefore, as the next step, we actually took this. We have, this is a bovine osteochondral explant, a biopsy, where we made a defect, and we took exactly these hydrogels, the hydrogels from before, and implanted them into a defect, into an artificially created osteochondral defect. Then, in this case, in that study, the defects were further implanted into the back, under the skin of mice. And then after 4 weeks, after 4 weeks, the explants were taken out and were examined by histology. Again, we can see, so this is the empty defect where no hydrogel was implanted, so no cells were infiltrated. The fibrin hyaluronan hydrogel again performed better than the hyaluronan tyramine hydrogel. So there were more cells here and more matrix in the defect. However, in this case, there was no effect of the chemoattractant. So while the hydrogel performed really well and allowed the cell migration into the defect, in this in vivo study, the chemotactic factors had no additional beneficial effect. However, so this is kind of, we still don't really know where the cells came from, because we think the cells came probably from the bone marrow, from the cartilage here, but we cannot exclude that some cells also from the animal were infiltrating. In any case, we had the best effect in the construct seeded with the fibrin hyaluronan hydrogel. Okay, then as a last step, we wanted to also here include the mechanical load, because as we showed before, mechanical loading is very important. And also in this in vivo study I showed before, there was no mechanical loading involved. Therefore, we set up a new study. So we kind of developed a new model. We developed a new model where we have again an osteochondral explant, in this case from a bovine knee. Then we make a chondral or osteochondral defect, and then we can implant cells and hydrogels in this defect, and then load the defect, so the explant with the defect, again in the bioreactor, instead of just loading cell-seeded scaffold. Before, I only showed the loading of cell-seeded scaffold, but here we can also load whole explants that have a defect and see in an even more physiological or more close to in vivo situation what is the effect of mechanical compression and shear. So these are just some examples to see how it looks. So we drill from a bovine whole knee, we drill the explants in a reproducible manner, osteochondral, nice osteochondral explants. Then we drill a defect. So again, this is 8 millimeter and the defect is 4 millimeter in diameter. And then we put these explants in the bioreactor and load them again with compression and shear in a similar way as we loaded previously just the cell-seeded scaffold. First of all, we had to check whether the cells were actually staying alive during the loading, and yes, during the period of loading. Here we had a 10-day culture period. We investigated the cell viability after 10 days of loading in both in the cartilage and the bone. We did this with the LDH staining, where all the blue cells are representing the viable cells, and the dead cells that are stained with ethidium homodimer would represent, so the red cells would represent the dead cells. We were happy to see that even in the loaded and in the unloaded samples after 10 days, there were hardly any dead cells. Most of the cells stayed alive, except here at the very surface, sorry. And even in the bone, we still can see a lot of living cells after 10 days. Yeah, which is a very, actually very positive finding. Then we looked how the loading affected the cartilage. So now these images are from this part that is not in the defect. And yeah, also here we were happy to see that the loading with the ball did not affect, at least on this microscopic level, not affect the cartilage surface. So the cartilage surface stayed intact. Also, there was no release of proteoglycans into the medium, which shows us that loading does actually not wear out the cartilage, because this was one of our concerns, that if we load, we actually could damage. But in this case, we did not damage the cartilage. We loaded the construct with 0.5 hertz, yes. Then we also we filled the defect, so the osteochondral defect is filled with a polyurethane scaffold. And again, just as a proof of concept, we first seeded chondrocytes into the scaffold to see whether we can reproduce in this model what we have shown previously, that the chondrocytes respond to the mechanical load. And yeah, it's nice to see that, again, the proteoglycan 4 and the COMP gene expression were really responsive to the load. So the cells here in the scaffold upregulated the gene expression of COMP and PRG4 and COMP for all the donors, which indicates that the cells responded appropriately to the mechanical load. Also, the collagen 2 to collagen 1 ratio was increased, and also aggrecan increased, which indicates that the load promoted the chondrogenic phenotype of the cells that are here in the scaffold, which kind of validates the approach and validates our model. So last but not least, we kind of took the best hydrogel from the previous, because I told you about the study where we tested different hydrogel and the cell migration in the hydrogel. and the effect of the different chemoattractants. So we put this hydrogel in the osteochondral defect with or without chemoattractants, and then we put it in the bioreactor, that defect. And our hypothesis was that the cells would migrate from the cartilage defect, so from the from the cartilage tissue into the defect under the influence of mechanical loading. So we hypothesized that the load would even facilitate the cell migration into the scaffold. However, here our hypothesis was not confirmed, was not proven, because we could see that in the case, this is now a histological picture, in the case of the mechanical loaded samples, we actually had less cells here in the defect than in the case of the unloaded samples. So here in this case, we can say the mechanical load in this case had more like a negative effect on cell migration. So because the exposure to mechanical stimuli tended to finally decrease the cell recruitment. From this finding, we concluded that probably in this case, a delayed onset of mechanical loading would be much better for cell-free treatment approaches to allow first the cells to migrate in, and then at a later time point to start with the loading when we have the cells in the construct. So as a summary, as a short summary of all these studies, we can say that this multi-axial mechanical loading, it favors the generation or regeneration of a functional cartilage matrix and functional surface with a low friction coefficient and a functional matrix. It also shows positive inflammation modulatory effect in a model of matrix assisted chondrocyte implantation. The multi-axial load, it induces chondrogenesis of bone marrow derived mesenchymal stem cells, and this is due to the induction and activation of TGF-beta. So induction means it on gene level and a protein level, and activation means if we have latent TGF-beta, it activates it to the active TGF-beta. However, we also found that in a cell-free approach, the mechanical load compromised early infiltration of cells. So here we have to be careful, maybe not to start too early with the loading. And of course, the hydrogel characteristics, especially in the cell-free approach, determines the recruitment of endogenous cells. And it is still a bit a challenge to find a good hydrogel, because the softer hydrogel are usually more cell-friendly, while the hydrogel that are stiffer are less cell-friendly, but maybe better for mechanotransduction. So just to conclude, our bioreactor is really helpful for testing of biologics and biomaterials and physical stimuli, and it is well in line with the 3R principle, because with these bioreactors we can kind of reduce or replace some animal studies that in that we can do some screening, and then maybe the best hydrogel, the best method would then maybe go into an animal study. It is clear that compression and shear load can promote the cell-based cartilage repair. However, in an early time point and in a cell-free approach, it could inhibit cell infiltration. And so therefore, depending on the patient and on the surgery, for example, in knee surgery, patient-specific rehabilitation protocols should be designed to improve the function of the therapeutics and the biomaterials. For example, like a skateboard activated motion might maybe be beneficial after autologous chondrocyte implantation, where we do have a slight compression and shear that would facilitate cartilage regeneration. So it would be good maybe to design a study in this respect. Yeah, with this, I'd like to thank my whole group, the AO Research Institute in Davos, the Regenerative Orthopedics Program, and the Disc and Cartilage Group, all my colleagues, collaborators, and students and fellow, also my international collaborations, and with all the consortium and all the funding sources. Yeah, and thank you for your attention. And yeah, I'm happy to take questions.
So thank you very much, Sibylle. That was brilliant. Really wonderful work. I congratulate you for such beautiful work. So please feel free to, you can put your hand up or just unmute and ask the question, because I can't see some of you on my screen. So questions.
Dr. Grad, may I ask a question?
Yes, please.
It was absolutely fabulous, your presentation, the way it was structured. Now we can see, it's lovely to see somebody that has your depth of expertise presenting a very complex thing and make it so easy and inspire us, and then we try to do it and it will not fly. But that's what the experience is. I have a very low tech question, because the high tech I will leave it to people that are better than me. Did you use windshield wipers motors for building your bioreactor movements? Because the way that they moved, it looked me that we might make that with windshield motors.
That's a very good question, and I can say I know, because I started with the development of this bioreactor when I started at the AO, which was 20 years ago, and the first bioreactor was actually with these wipers. Yeah, the first one was indeed. In the meantime, we have like a 6th generation version that is just a motor based. Now I'm not the engineer, I cannot tell you exactly which kind of motor.
Better granting, better money, better motor. Yes, better money, better motor. But yeah, because right,
we have started with those. Yes.
Okay, so it's okay. Thank you very much. It's ingenious. It's absolutely fabulous.
But thank you for the question. Actually, also it is true, you are the first who asked me this, and so I appreciate it. Yes,
you're welcome. I built a long time ago. I helped building in a bioreactor, and we were actually trying to figure out things that were never done. So I assumed what I would do to this, because it's an extremely incredible, ingenious idea that was used in there.
Yeah. So in the meantime, we have engineers who really help us with that.
Right. Thank you very much. Appreciate it.
You're welcome.
Thank you very much, Ovidio. Derek looks like somebody with a question.
Hi, Sibylle. Nice to see you. Quick question about the end bit of work that you showed with the implant and the osteochondral defects. Very interesting. You used the polyurethane sponge. So what was the motivation to use the polyurethane sponge as opposed to other types of hydrogels that many labs use for this type of work? And is it a biodegradable type of polyurethane or a non-biodegradable type of polyurethane?
Thanks for the question. So that's a good question. So the main motivation is that we are still using the polyurethane is that it has by far the best mechanical properties for an efficient stimulation of the cells, so also efficient mechanotransduction. In the meantime, and I have to thank Martin for this, is mainly Martin Stoddard's work with the TGF-beta induction. They found out that if the scaffold is too soft, the activation of the latent TGF-beta is not happening. So apparently it needs a certain stiffness to have the direct mechanical input, the direct mechanical impact to actually activate latent TGF-beta to active TGF-beta. And this, so far, it works far the best with the polyurethane scaffold. All the hydrogel we have tested so far can also not be loaded in a really high amplitude and frequency, because they are either too brittle or too soft, or they are not resilient enough, so they would not come back if you release the load, and therefore we are still using the polyurethane. This is more like, for us, it's more a model than really something we would implant. It's a model to see the response of the cells. The scaffold itself, it is biodegradable. However, it has a very long degradation time. It would probably in vivo take months, several months, or even year to degrade. It is slowly biodegradable.
Is that necessarily a bad thing, though, if you want some mechanical support while the tissue is regenerating? It's a philosophical question.
It's a good question. I mean, we know if we use it just as a model, the in vivo situation would still be then a bit different. And therefore, we are actually looking at other hydrogels. What I said also at the end, we are looking at other solutions that are more, would then be more clinically relevant. But so far, we are working on it. So the other group, the biomedical materials group, are working on a hydrogel that has the mechanical properties to actually have the same mechanotransduction effect as the polyurethane scaffold. But so far, yeah, it's a very challenging task.
Yeah, but I agree that, I mean, there's implantable polyurethanes, medical grade polyurethanes, implantable, so it's not such a bad idea. It looks good to me. Okay, thank you.
Yeah, you're welcome.
Wonderful. Anybody else? Dr. Chevalier, did you have a question?
Yes, very nice presentation. I really liked it. And of course, it's not my area, but very nice to see how you can manipulate the cells and the factors to get some regeneration. My question concerning the last part where you have this bovine joint, where you create the defect and then add up whatever you want to study. How long do you wait before you're adding the gels or the factors to kind of, because there is a kind of a stress, I would think, that is induced when you create the defect, and that may call up cells that can cooperate with what you're doing, in contrast to maybe a human where the joint may take a long time to cause the defect, and then that you don't have the same, I would say, stress, which is chronic as acute. I mean, that's I'm trying to do the translation, but the time is the time where you said that at the end that you did not get all the results you expect. Could that be a reason, or have you studied the better time to do this?
Of course, the timing is important. What I actually mentioned at the end of the presentation, the timing is important, and we are not yet there. It's true. So in our case, we usually extract the osteochondral explant on the first day, and then on the second day, it's 1 day later, that we put in the hydrogel. So, but it's well possible that there is, of course, the cells are stressed, especially at the border where we drill. Also, we try to drill it very gently. We try to not produce any heat, because you could think, not produce any heat. We drill it very gently, but nevertheless, just the mechanical injury itself definitely has a stress effect on the cells, but that might influence then the cells' response to the hydrogel and the load. This is true. Regarding the human, more recently we have had good access to human samples. However, then it's a bit a different thing, because the human samples where we have access to, and also human cells, they're all diseased. So it's from mainly from hip replacement surgery. We have a good collaboration with the hospital, with the local hospital, but if it's from hip replacement surgery, and we have now also started with human explants and so on, which is definitely then a different approach. But even this, if it depends what we would like to reproduce. If we would like to reproduce a focal lesion, a cartilage lesion, then it's more relevant for younger people. Then in this case, the old osteoarthritic cartilage might also not be the relevant model. But we are now currently using 2 models, also the human. It's a very interesting, it's a really interesting suggestion. And the timing, and yes, with respect to the timing, so what we think would help if we wait, maybe we can wait longer with filling the defect, and then even have it maturating a bit, and then wait with the loading, because even the patient would not load the next day, necessarily load already the next day, but rest a bit and then start with the loading after a few days or weeks.
Because the bone with the defect per se is kind of a culture itself. If you put it in proper condition, then you can see what would happen, and then the best time to intervene, maybe. I don't know. I'm just thinking of how the cells that are there are kind of activated by this drilling as well. Even though it may be soft, it's not a normal process.
It also just representing one. We are also working on other models, for example, just a high impact load, or like again an inflammatory model where we add some cytokines to simulate an inflammation response. So it depends what we would like to model. Right.
How big would be these kind of scaffold if you would introduce this in a joint? If you're thinking of going in a human, because of course from the diagram here, it seems big to me for what we, so I was wondering whether it can be something more flat or more in other forms. If you think, I don't know what's the dimension that would be ideal for an inoculation.
This is true, and we even concluded this as well from our last study, that probably also the defect was a bit too big. I mean, if we had a smaller defect, there would also be a better chance to see better regeneration. I fully agree with you. That was a bit.
But it's neat. I mean, when you think about it, it's a kind of a neat model, and you're getting results, and it gives you factor that can be important, like the TGF-beta activation. So I mean, it is an active model, which is very neat. But I'm just trying to think how big would that be if I would like to have this in my knee.
No, I fully agree with you that this was more like a proof of concept.
Yeah,
absolutely, nice. Absolutely.
Very nice. Thank you.
Thank you. So Lisbeth, then Annie.
Hi, Sibylle.
Hi, Elizabeth.
Thanks for a very nice presentation. You know, it's a long time since I heard anything about COMP, so I'm a bit interested in COMP, and I'm sure you know that COMP was one of the biomarkers that they tried to use as an OA marker, blood marker for arthritis. But the interesting thing with COMP was that it's also released a lot if you exercise. So it was hard to use it as a biomarker because mechanical loading by itself induced the expression. So I wonder what you know about the COMP that you see in this model. Is it the intact molecule, or are there specific parts of COMP that are released in response to arthritis and or to just physiological loading like exercise?
That's a very interesting question, and yeah, the thing with COMP, it's often discussed, and especially because COMP is actually known as a degeneration marker. So when I say, oh, COMP was upregulated, then people say, but that is bad. So, but in this case, we think that we don't know whether it's a different. It would be interesting to investigate it. Whether it's a different, because, I don't know, type of COMP, but we see it, I think, in this case, it's a regenerative response, because COMP is necessary to for the matrix. It's one of the most important non-collagenous matrix molecules, so it is necessary for, for the function of the matrix. So I see it in as a regenerative response, and I guess in the case, and it's maybe just in the case of the degeneration, it's released because the cartilage is broken down. But why it's released in case of just normal exercise, I don't know whether there are small tiny injuries when you exercise a lot, but that is not harmful, because if it's then released in OA, I see it released as a response, as a sign of cartilage breakdown.
Yeah, but
yes, but it would be interesting to see whether there are different. I don't know too much honestly about COMP, whether it has different isoforms or different, or whether there are even fragments you would detect.
Yes,
with
there is fragment. But I don't think it's known what is being released as a response to exercise and what is being released as a response to OA. I just know that it was one of the big issues with the assay when they looked at it in Lund, the fact that if a perfectly healthy individual went for a good run, and then your COMP levels will be up. So it was a difficult marker because it is a degeneration marker, but it's also a marker of just, I guess, tissue remodeling. So I would be interested to know more about, if there are differences in that.
But if you know whether there are whether there is an assay or a method to distinguish different isoforms of fragments, then it would be easy, because we have always studies running in the bioreactor project, and then we always collect the cell culture medium or tissue culture medium. It would be easy to measure it if there are assays or methods to differentiate. It would be an interesting project, in fact. We always measure things in the medium.
Yeah, we should talk more about that. And another very quick question, just about your hydrogel. You said you have fibrin in your polyurethane scaffold. Did you ever try, like, for example, collagen 2? Why fibrin?
Originally, we had fibrin because we wanted to reproduce, for example, if you do the microfracture, you would also have like the blood and the bone marrow, and then you would also have like fibrin naturally in there. We wanted to reproduce this situation. And then we found out that it's actually working quite well, but otherwise, it also works with different hydrogels. We did once a collagen, from a collaborator. We had other hydrogel that show a similar effect. There is no other reason for the fibrin.
Okay, good. Thank you. I really like that model. I think it's so cool. Yeah. Thanks.
Annie.
Thank you very much for an excellent. Thank you very much for the excellent talk. Yeah, my question is regarding the TGF-beta mediating the loading effects. So, do you think how much of the beneficial effects of loading is mediated by TGF-beta? In other words, if you neutralize the TGF-beta activity using a TGF-beta antibody, for example, can you get rid of most of the benefits from the loading? Or, that's one.
Yes.
Yeah.
Mm-hmm. Yeah, thank you for the question. We did not do this with chondrocytes, but we did do this experiment with, actually my colleague also, with mesenchymal stem cells. And in fact, when the TGF-beta receptor was blocked, the response was blocked. So it is in terms of the chondrogenic response, it is really TGF-beta mediated. So when we block the receptor, the response is diminished. Yeah, right.
Yeah, that brings up the question, whether it's production versus activation, how much of it is due to production, mRNA or synthesis versus activation. That's an interesting question. And then which cell type, when you have bone marrow cells instead of chondrocyte, you might be getting the TGF-beta, we can assume, from the bone MSCs rather than the resident cells, right? Or that's that possibility. Or why not just instead of loading why loading can be replaced by TGF-beta? You can just inject TGF-beta and get that.
We have found that there was a study that compared. So first of all, we found that that in general chondrogenic medium you usually add something like 10 nanogram per milliliter TGF-beta in standard condition. If we load the construct, we get about 10 times less. So first, and we think that's probably more physiological levels, and that and we know that high TGF-beta actually also has negative effects. It can also induce bone formation. It can induce hypertrophy and so on, which is still also a bit something we have to work on it, because even in the bioreactor, with time the cells tend towards hypertrophy. We still could not stop it completely. And to answer the other question, there was a study comparing with microarray the whole profile of the gene, like the whole expression profile of the cells after exposure to TGF-beta versus after exposure to the mechanical load. And there were quite significant differences in the overall gene expression, or was it proteomics? It was not me. I think it was microarray, gene expression array. There were really striking differences between cells that were stimulated by the mechanical load to induce the TGF-beta and other things, versus cells that were just stimulated by a same amount of TGF-beta as you have in the loads. So this also tells me the TGF-beta plays a major role, but there are other factors that contribute also to the response. Yes.
Absolutely. For example, TGF-beta's effect on synovial fibroblasts is very counterproductive. It causes growth, etc. So
exactly.
TGF-beta has a multiplicity of effects, and every cell type, it has a different effect. And when the microarray was done, was it on pure chondrocyte population, or was it a tissue-based microarray?
In this case, no, it was bone marrow derived, human bone marrow derived mesenchymal stromal cells.
Okay. Yeah.
And we always, when we do these studies with the MSCs, we never take like cell lines, or we really always work with primary cells. We isolate ourselves from human patient to also kind of because this is what happens in vivo, and to also include the variations we have. For example, in one patient, we can have a huge response of like 1 million upregulation, and in the other patient, maybe only 100 times upregulation, but we have always the same trends, and we are on purpose. And Martin's group is even looking specifically at donor variation. It's a very important topic, that we don't just take one cell line or one donor, one commercial donor that is we know it's very responsive. We always test several different cells from several different human donors. We isolate ourselves as primary cells. Yeah.
Thank you so much.
You're welcome.
Well, thank you, Sibylle, for that really wonderful talk. I have just two questions. So one of the holy grails of cartilage repair is the formation of hyaline cartilage. And so one of the things when you're doing tissue engineering, people ask, you are forming fibrocartilage. Are you forming hyaline cartilage? So of your constructs, especially when you have TGF-beta involved, there's this whole thing that is it pushing to making type 10 collagen, for example. So of your different hydrogels, which of the conditions, because I saw you did really wonderful work looking at the ratio of type 2 to type 1 collagen. So which one do you think approximates the hyaline cartilage?
You mean which of the hydrogels?
Yes. Which one do you think? So you have the polyurethane. Yes.
So yeah, we have not tested too many yet, but so from the ones we have tested, these 4 hydrogels I showed, I think this fibrin hyaluronan hydrogel was probably the best one.
Okay.
This is it is from a collaborator. So this was in the context of a collaborative project, and it's kind of a company from Israel, and they are developing specific fibrin hyaluronan hydrogels. They are now further developing them to make them a bit, also a bit mechanically more competent. I think as just a hydrogel for to promote the collagen, to promote hyaline cartilage formation, it is very suitable. It is very promising. And I think one of them even has already used in some clinical trials. However, the drawback is still the mechanical competence. For example, when we loaded these hydrogels, we could only apply quite gentle load. Again, we can just embed it in the polyurethane scaffold, and then we can apply the load when we have the hydrogel in the scaffold. But for the final clinical application, we really would like to have the hydrogel itself. So I would say from the ones we tested, this fibrin hyaluronan shows the promising results so far.
Right. So when you are using the stem cells, you with the chondrocytes in the other experiments, you documented really nicely the lubricin with compression and shear, which was really elegant and absolutely beautiful. So with the stem cells, were you also getting that nice band of lubricin?
Yes and no. I mean, yes, but not very reproducibly. So this is a bit an interesting observation with the lubricin in the stem cells. There are large donor variations that in one donor we see it. We see it nicely, and in other donors they are not so responsive, and we still don't know what is the reason behind. Yeah, but in principle the trend is always there. Yes.
Right.
It's just not so obvious. Yeah.
Right.
The trend is there. Yeah. Mm-hmm.
Oh, that's brilliant. So thank you very much, Sibylle, for that wonderful. I would like to have on my wish list have that bioreactor.
For next Christmas.
So next time I come to Davos, if you find the bioreactor is missing.
Yeah.
So thank you.
No. I mean, we were talking a lot about having a bioreactor for all the labs, and then we also have discussed this often also for the spine. But then finally we concluded maybe it's nicer if you have a good idea or something you would like to test. Then we start a collaboration, and you have the material or the idea or the implant, and we have the bioreactor, and then we collaborate and leverage our research. Yeah,
that would be really nice. I like that whole mix of putting together compression and shear. Really wonderful. So thank you very much, and thank you everyone for attending this seminar. Happy New Year. I hope this year is better than last year. Thank you.
Yeah, I also hope I see you face to face at an occasion. Yeah. Thanks, everyone.
Thank you.
Goodbye.
Bye-bye. Thank you.
Bye.
Bye.